All right, let's dive in. Today, we are taking a deep dive into a topic that is absolutely fundamental to understanding the complexities of modern cancer care.
Yeah, it really is.
We're talking about infections in patients with
Yeah,
cancer. And this isn't just, of a footnote.
not at all. It's a critical challenge,
Yeah.
can really impact outcomes.
It often leads to severe illness, complicates treatment, and, well, tragically, it can even be fatal.
Mm-hmm.
So if you really want to understand the full picture of caring for or navigating cancer, I mean, mastering this area is just essential.
Exactly. And this deep dive, it's built around Chapter 74 of a pretty comprehensive medical text.
Okay.
Our goal here is to really get into the weeds of it, explore every key concept, every detail.
Until we've built that kind of mastery level understanding.
That's the aim. The elite professionals in this field rely on every single day.
Right, okay. Think of this as gaining the insights needed to appreciate the sheer complexity and, well, the vulnerability involved.
Yeah.
It's a fascinating subject, I think, because it puts into sharp focus this constant dynamic interplay between the cancer itself, the powerful tools we use to fight it, and the body's own defense systems.
And it's not static, right? The infection landscape is always changing. As the source material makes clear, the evolution of cancer therapies is continuously shifting the risks.
So?
Well, historically, cytotoxic chemotherapy was the big driver of infection risk, mainly by causing low blood counts, neutropenia.
Right.
But now you have newer treatments like checkpoint inhibitors, PRRT cells. They bring entirely different kinds of vulnerabilities, new pathogen risks.
Okay, so to really master this, we have to understand the root cause. Let's unpack that core challenge. Why are cancer patients so, well, prone to infection?
Good place to start. The source material really breaks this down into two fundamental areas.
Which are?
Problems caused directly by the cancer itself, and then problems caused by the treatments used to fight the cancer.
Makes sense. Let's start with the cancer's direct impact.
Spot on. So, first, the cancer isn't just passive, right? It can actively mess with normal body functions. The source talks about tissue invasion.
Like physically taking over.
Exactly. Imagine cancer cells just proliferating, replacing healthy, normal cells. Think about the bone marrow.
The blood cell factory.
Right. Your factory for blood cells, including white blood cells, the soldiers of your immune system. If cancer takes over that factory...
You can't make enough soldiers.
Precisely. Leading to conditions like neutropenia, a severe lack of neutrophils, a key type of white blood cell. That's a direct hit from the cancer itself.
And it's not just replacing tissue, you said.
No, it can also physically block things. The source highlights how tumors can cause occlusion, blockage of orifices.
Okay, why is that such a problem?
Well, a lot of the body's defenses rely on continuous flow, like flushing things out. Think about a tumor blocking a ureter, the tube from the kidney to the bladder.
Okay.
If urine flow stops, any bacteria that get in there can just multiply like crazy, leads to severe UTIs.
Ah, I see. Same principle elsewhere.
Yeah, same idea if a tumor blocks a bile duct. You can get cholangitis, infection of the bile ducts. Table 74.1 in the source gives examples: renal cancer, ovarian, biliary tree cancers, even metastases can cause these blockages.
So preventing that normal flow, that emptying of an organ, it just creates a stagnant pool.
Basically, yes, a perfect breeding ground. And the source stresses this can lead to really rapid, overwhelming bacteremia.
Bacteria spreading through the bloodstream. Scary.
Yeah, very. So that's the cancer doing damage directly.
Okay. Then there are the treatments designed to kill cancer, but they often hit healthy cells too, right?
Especially fast-dividing ones, like in the bone marrow or the lining of your gut.
So chemotherapy is the classic example here.
Historically, yes. Cytotoxic chemo was the main driver of infection risk. Its primary way of causing vulnerability was, again, neutropenia.
That low white blood cell count.
Because it doesn't really it kills those rapidly dividing immune cell precursors in the bone marrow.
But you mentioned newer therapies are changing things.
Right. The source emphasizes that while chemo-induced neutropenia is still a massive factor, these newer, more targeted therapies, they introduce new layers of complexity.
Okay.
Checkpoint inhibitors, immunomodulators, CRT cells, they're revolutionizing cancer treatment, no doubt. But they work by manipulating the immune system in very specific ways.
So maybe not the same kind of broad wipeout of neutrophils?
Not always, no. But they can significantly alter the function of other crucial immune cells, like T cells or B cells. And the source notes these newer therapies are particularly linked with increased risk from intracellular pathogens.
Bugs that hide inside our own cells.
Exactly. Microbes like certain viruses, fungi, bacteria that multiply inside host cells. Clearing those requires a specific immune response, often involving T cells.
And if that response is altered by the therapy,
Then these stealthy pathogens can become a really serious threat.
it really is like playing a different kind of defense game depending on how you're attacking the cancer.
Wow, absolutely.
Now, it's not all doom and gloom. The source gives this fantastic historical perspective, outlining 3 major steps that have dramatically cut infection-related deaths in cancer patients over the decades.
Yeah, it's a story of real medical progress, driven by necessity. Shows how much we've learned.
So what was the first big step?
Early treatment. Sounds simple, but just recognizing the risk and acting fast made a huge difference. The source cites really striking data.
Like what?
For leukemia patients with bacteria in their blood, mortality rates plummeted from a horrifying 84% back in 1965,
84%.
down to 44% by 1972.
Wow, just from acting sooner.
Primarily, yes. And the source points out that by 2013, mortality rates from infection in patients with febrile neutropenia, that's fever plus low neutrophils, were actually less than 10%.
Less than 10% from over 80%. That's incredible progress.
Truly dramatic. And the key insight, according to the source, was that timing is critical. You can't wait days for culture results.
You have to act on suspicion, especially in high-risk patients with fever.
Immediately. Start appropriate antimicrobial therapy right away.
Which leads right into the second step, doesn't it? Empirical treatment.
Exactly. Treating a presumed infection based on the most likely culprits in that specific situation, even before you have lab confirmation.
And the source highlights this particularly for fungal infections.
Yes, empirical antifungal therapy became really crucial. Think about those neutropenic patients who stay febrile despite several days, maybe 4 to 7 days, of good broad-spectrum antibacterial therapy.
And their cultures aren't growing anything specific.
Right, so you've covered the usual bacterial suspects. They're still sick, still neutropenic. The odds of a fungal infection go way up, even if you can't culture it yet.
Because fungi can be harder to grow in the lab early on.
Notoriously so. Recognizing that high risk and empirically adding an antifungal agent has dramatically lowered the incidence of those really bad disseminated fungal infections and cut mortality.
Okay, so early treatment, then empirical treatment. What was the third step?
Prophylaxis. Taking it even further, giving antibiotics or antifungals before any sign of infection even appears.
But only for really high-risk patients.
Exactly. Specifically for patients who are anticipated to become severely neutropenic for a prolonged period.
So like before they even start a certain chemo regimen.
Or right when the neutropenia begins. This proactive strategy further reduced both morbidity and mortality. The source outlines the current kind of layered approach often used for these high-risk patients, say, getting intensive chemo for leukemia or high-grade lymphoma.
What's the sequence?
You start with prophylactic therapy when neutropenia begins. If they develop a fever despite that, you escalate to empirical antibacterial therapy.
All right.
And if the fever persists for several days on antibacterials and you still haven't found a bacterial source, then you add empirical antifungal therapy.
So it's a strategic framework.
Yeah.
Prevent if possible, hit hard empirically if fever starts, and then broaden coverage based on likelihood if the initial plan isn't working.
You got it. It's a logical progression based on risk and response.
Okay, let's circle back to those predispositions. You mentioned the direct effects of the tumor, but let's dig into the physical factors listed in Table 74-1 a bit more. Breaks in the skin and mucous membrane seem obvious starting points.
Yeah, there are primary physical barriers, right? Skin, the lining of our mouth, gut, urinary tract. If those barriers get breached, microbes that normally live harmlessly on the surface or inside can invade.
And cancer itself can cause those breaches.
Absolutely. A squamous cell carcinoma invading the skin creates an opening for bacteria, leading to cellulitis. The source mentions head and neck cancers as examples where this is a particular issue.
And treatments like chemo and radiation damage those linings too, right? Mucositis.
Exactly. That ulceration in the mouth and gut leaves the underlying tissues exposed. It's a major gateway for bacteria and fungi.
We also talked about tumors blocking orifices occlusion.
Right. And the source really reinforces how preventing that continuous emptying, whether it's urine or bile or whatever, lets even a few bacteria multiply into a huge population. It's that stagnation problem again.
Creates a perfect environment for them. What about lymphatic dysfunction?
This is often a consequence of cancer surgery, especially when they have to remove a lot of lymph nodes. Think radical mastectomy for breast cancer.
Removing nodes disrupts the drainage system.
Precisely. It impairs the normal drainage of lymphatic fluid from the tissues.
leading to lymphedema, that's swelling.
And that stagnant, protein-rich fluid is like a perfect culture medium if bacteria get through a small break in the skin. Predisposes patients to recurrent cellulitis.
Usually common skin bugs.
Typically streptococci or staphylococci, yeah. Managing the lymphedema itself is key, but the source notes sometimes prophylactic antibiotics are needed if infections keep happening.
Okay, here's one the source really emphasizes.
Yeah.
Loss of splenic clearance.
Ah, yes, the spleen. It plays a critical, often underappreciated role in filtering bacteria out of the bloodstream,
Especially certain kinds.
especially those with a polysaccharide capsule, basically a slippery coat that makes them hard for other immune cells to grab onto.
And when the spleen is removed, splenectomy. Maybe for a blood cancer like hairy cell leukemia or Hodgkin's.
That filtering capacity is just gone. And the source hammers this home. It's a lifelong vulnerability, even if the cancer is completely cured.
Lifelong risk of what specific?
Rapidly overwhelming, potentially fatal infections. The source lists specific organisms the spleen is good at clearing. Babesia, a protozoan from ticks. Capnocytophaga canemorsis, which is in the mouths of dogs and cats, even a minor scratch can cause severe sepsis in someone without a spleen.
Wow.
And most importantly, the encapsulated bacteria.
Those are the big three, right? Streptococcus pneumonia, Haemophilus influenza, Neisseria meningitis.
Exactly. Pneumococcus hypermeningococcus. Infections with these can escalate incredibly fast without a working spleen.
So what do you do for these patients?
Aggressive vaccination strategies are crucial against those encapsulated bacteria. Table 742 in the source details the vaccines, the schedules, the need for revaccination sometimes, especially after immunosuppressive therapy or transplant.
And the source mentions giving patients antibiotics to keep on hand.
Yeah, that practical advice giving splenectomized patients a small supply of empirical antibiotics like amoxicillin clavulanic acid or levofloxacin, it underscores the urgency.
So if they get a fever and can't get help immediately,
Taking those antibiotics could literally be life-saving. Buys critical time, it's a vital safety net.
makes sense. Moving down table 74-1, impaired phagocytosis.
Right. Phagocytes, like neutrophils, are the eaters of the immune system. They engulf bacteria.
Pac-Man, basically.
Kind of, yeah. Impaired phagocytosis is directly linked to not having enough of them granulocytopenia, especially neutropenia, if you don't have enough eaters.
Invaders don't get cleared.
Exactly. This is a defining feature of acute leukemias, AML and ALL, where cancer crowds out normal production. Also seen in hairy cell leukemia.
And what kind of bugs thrive then?
The source lists the usual suspects: staph, strep, enteric organisms from the gut, fungi. Without enough neutrophils to contain them locally, they easily get into the bloodstream, bacteremia, fungemia.
Okay, that covers the physical barriers in the main eater cells. But the immune system is more complex, right? Table 74-3 gets into specific immune abnormalities.
Yes, this is key because different cancers and treatments hit different parts of the immune system, leading to specific vulnerabilities. First up, hypogammaglobulinemia.
Low antibodies.
Right, a deficiency in antibodies, those proteins made by B cells that tag pathogens and neutralize toxins.
And the source links this to cancers involving B cells themselves, like multiple myeloma or CLL.
Correct. And guess what? Pathogens become the major threat.
Let me guess. The encapsulated bacteria again.
Spot on. S. pneumonia, H. influenza, and meningitis. Antibodies are crucial for marking these slippery guys. So low antibodies often means recurrent sinus infections, pneumonia from these specific bacteria.
It's like missing the tags makes it hard for the other immune cells to find them.
Exactly. Similar vulnerability to missing the spleen, just a different mechanism. The source notes that while giving immunoglobulin replacement therapy, IVIG, can help, for many CLA patients, simpler, cheaper prophylactic antibiotics are often effective enough to prevent these infections. Routine IVIG isn't always needed.
Okay, what's next? Abnormal T cell function.
This is about impaired cellular immunity. T cells are crucial for fighting pathogens that live inside our cells, plus controlling viruses and fungi.
And this defect is seen in things like Hodgkin's lymphoma, certain leukemias, T-cell lymphomas.
Yes. And look at the associated pathogens in Table 74-3. It's a different list.
Intracellular bacteria, M. tuberculosis, Listeria, Salmonella, fungi like Cryptococcus, herpes viruses, parasites.
Right. When T-cell defenses are down, these stealthy pathogens that hide inside cells or need direct cell killing can take hold. It also ramps up the risk of latent viruses like VZV, shingles, or CMV reactivating.
It's like lacking the right kind of special forces for specific missions.
A good analogy. The source also lists granulocytopenia again here, linking it with skin mucous membrane lesions in AML patients' risk for extracellular bacteria and fungi.
And there's a really crucial point connecting specific treatments to specific risks, isn't there? Glucocorticoids.
Yes, therapies involving glucocorticoids, steroids, or drugs that profoundly mess with T and B cell function. Like for non-Hodgkin's lymphoma, ALL, or some newer agents, they create a significant risk for pneumocystis infection.
PCP pneumonia, the classic opportunistic infection.
Exactly. That's why prophylaxis, usually with TMP-SMX, is absolutely critical for these patients. Mandatory, really.
Okay. And lastly, in this section, the source mentions a specific association with colon cancer.
Yeah, this one's interesting. Colon and rectal tumors are linked to bacteremia with Streptococcus bovis biotype 1. The source admits the exact reason isn't totally clear.
But if you find that bug in the blood,
You have to look for a colon or rectal lesion, like a polyp or a tumor. It's a very specific clinical clue.
that kind of association is invaluable. Okay, let's shift to diagnosis. This sounds like one of the trickiest parts.
It absolutely is, and the core reason is that altered host response we keep mentioning.
Because the immune system isn't mounting that normal visible reaction. Redness, swelling, pus, fever.
Exactly. If you don't have enough white blood cells or their function is suppressed by drugs like steroids, that classic inflammation is muted or just absent.
So fever, which is usually a reliable sign.
Still pretty reliable in neutropenic patients, which is why empirical therapy works. But patients on high-dose steroids or T-cell suppressing drugs can have serious widespread infections without a fever. That primary alarm is silenced.
That's incredibly dangerous. Makes it so much harder to spot early.
And other signs are misleading too. A neutropenic patient might have severe cellulitis, but it won't look like the red, angry, pus-filled infection you'd expect.
No pus, because no neutrophils to make it.
Right. They might have pneumonia, but no productive cough, no sputum. A doctor listening might not hear the usual crackles or consolidation sounds. Even chest x-rays can look deceptively clear early on.
Because they lack the cells needed to create that visible inflammation or infiltrate?
Precisely. So you need a much higher index of suspicion based on subtle changes. You have to rely more heavily on advanced imaging, lab tests, rather than just the classic signs and symptoms.
Okay, so where do these infections typically show up? Let's walk through the system-specific syndromes the source describes, starting with the skin.
Skin infections are common, yeah. You see typical cellulitis, but in neutropenic patients, the source highlights unusual bugs and presentations.
And that warning about innocent-looking spots or bumps, macules, or papules potentially being the first sign of systemic sepsis, that feels critical.
Absolutely. Don't ignore a new skin lesion in these patients, no matter how small it looks. Figure 74:1 in the source shows just how fast things can progress.
Is there a classic example?
Ecthyma gangrenosum is the classic, though thankfully less common now. The source describes it vividly. Usually painless, round lesion, rapidly develops a black necrotic center, and eschar with redness around it. Often pops up on non-pressure areas like arms or legs.
And that's strongly linked to?
Pseudomonas aeruginosa bacteremia, a really nasty bug in immunocompromised hosts. Though other bacteria can sometimes cause similar lesions, the key is its rapid progression from just a little spot in a neutropenic patient.
Any other specific skin signs?
Candidemia, candida fungus in the blood can present as a maculopapular rash, little bumps and spots. The source even points to a picture, figure A137.
And you can diagnose it from the rash.
The punch biopsy of one of those lesions can be a great way to diagnose disseminated candidiasis, yeah.
Going back to basic cellulitis in neutropenic patients, what are the key takeaways?
Rapid spread, lack of pus, and potentially really severe outcomes. The source mentions things like amputation from what might just be a simple boil in a healthy person. Early recognition is everything.
The source also mentions something called sweet syndrome.
Ah, yes, febrile neutrophilic dermatosis. It's fascinating. Ironically, first described in patients with high white counts, but now often seen in neutropenic cancer patients, especially with AML.
What does it look like?
Distinct red or bluish-red bumps and nodules, often face, neck, arms. They can merge into plaques. They might look swollen like blisters but feel solid. Usually comes with fever and high ESR.
And how do you know it's that and not infection?
The dramatic response to steroids, like high-dose prednisone, it's a sterile inflammation, not an infection, but it sure looks like one and happens in this setting.
Okay. Erythema multiforme and Stevens-Johnson syndrome are also mentioned.
Yeah, these are severe skin reactions. In cancer patients, erythema multiforme is often linked to HSV reactivation due to the immunosuppression. Stevens-Johnson is more often a severe drug reaction. Mucous membrane involvement is key for EM. SJS is even more widespread and dangerous.
And finally, cytokine therapies can cause rashes that complicate the picture.
Especially in transplant patients where you're trying to distinguish it from graft versus host disease or viral rashes, it gets tricky.
Okay, moving on from skin, a huge site of vulnerability. Central venous catheters, those IV lines.
Oh, absolutely huge. They're essential for giving chemo, fluids, meds, but they're direct highways for microbes straight into the bloodstream. A major challenge.
So management decisions are key. Table 74-5 is referenced, talking about treating with antibiotics versus pulling the line.
Right. And the answer often depends on the type of catheter and, critically, the bug involved. The source defines a tunneled catheter one that goes under the skin for a bit before entering the vein.
And the rule there is?
If there's infection along that tunnel redness, tenderness, the catheter must come out immediately. Infection tracked deep along the device is highly likely to fail antibiotic treatment alone and can cause nasty tissue damage.
Non-negotiable removal. What about infections just at the exit site where it comes out of the skin?
More common. For the most frequent culprit, coagulus-negative staphylococcus, the source says many experts recommend trying antibiotics first, usually vancomycin.
So you might not have to pull the line.
If the patient's stable and the infection responds quickly, maybe not, though removal is still often considered optimal. But for other, more aggressive or hard-to-treat bugs, removal is much more strongly recommended.
Like which ones?
Coagulus-positive staph, like S. aureus treatment, often fails without removal. Also, Pseudomonas aeruginosa and Candida species. Fungal catheter infections are notoriously hard to clear with just meds.
And there's a list of others where removal is almost always needed.
Yeah, bacteria like Burkholderia cepacia, Stenotrophomonas, Acinetobacter, non-aeruginosa, Pseudomonas, carbapenem-resistant ones. Also, Bacillus, Corynebacterium, Mycobacterium. If you isolate those from the line, it generally needs to come out. Fungal infections, again, almost always require removal.
Okay, let's move into the gut. Gastrointestinal tract infections. Upper GI first, the mouth.
Very common sight, especially with chemo-induced mucositis. That breakdown and ulceration of the lining
Destroys the barrier.
allows the normal mouth bacteria and fungi to invade tissues and get into the bloodstream.
Which bacteria specifically?
Bacteremia from Viridin streptococci, normal mouth residents, is strongly linked to mouth ulcerations.
And Candida.
Thrush. Extremely common. Thrush in the mouth, esophagitis lower down. Fluconazole works for the common C. albicans, but the source notes resistance happens, needing other drugs like voriconazole or echinokindins.
The source mentioned something called noma.
Cancrum oris. It's a severe destructive infection of mouth tissue. Rare, but they note a counterpart in immunocompromised patients linked to debility, poor hygiene, immunosuppression invasion by normal mouth flora like Bacteroides fusobacterium.
And herpes simplex virus.
HSV reactivation can cause painful esophagitis. Fortunately, treatable with a cyclover and prophylaxis works well.
Okay, moving down. Lower GI hepatic candidiasis.
Also called chronic disseminated candidiasis.
Yeah.
Basically, candida spreading to the liver, often from the gut, usually in patients who've been severely neutropenic. AML patients are classic examples.
And interestingly, it often shows up after their counts start recovering.
Yeah, it's like the recovering immune system finally mounts a response, causing symptoms like persistent fever despite antibiotics, belly pain, nausea, and especially a high alkaline phosphatase level.
Diagnosis sounds tough.
Can be. Biopsy might show fungus, but blood cultures are often negative. Imaging is key ultrasound, or CT might show bullseye lesions. MRI is more sensitive.
The biopsy is risky.
Often avoided due to bleeding risk. So diagnosis is frequently based on those characteristic imaging findings. And they call it chronic disseminated because other organs like the kidneys can be involved too. Treatment targets the specific candida.
What about typhlitis?
Necrotizing colitis, neutropenic colitis, different names for the same thing. It's a clinical syndrome. Fever plus tenderness, typically in the right lower quadrant of the abdomen in an immunosuppressed person.
Classically seen after chemo, especially in kids or MLL patients.
That's the classic association. Physical exam finds the tenderness, sometimes bloody diarrhea. Imaging confirms it thickens cecal wall on CT, MRI, or ultrasound.
And management.
Medical therapy is the mainstay. Broad-spectrum antibiotics targeting gut bacteria. Surgery is sometimes considered if there's perforation risk, but the source notes most cases get better with medical therapy alone.
Okay. And finally, C, diff, diarrhea.
Clostridioides difficile. Critical point here from the source. Cancer patients are predisposed just from getting chemotherapy alone, even without antibiotics.
That's important. Not just the antibiotic effect.
Right. The chemo itself likely disrupts the gut environment, so C. diff has to be on the radar for any cancer patient with diarrhea, especially post-chemo or antibiotics. Testing is essential. The source mentions work on new approaches to make it less of a problem.
Okay, let's move up to the central nervous system. CNS infections. Serious stuff. Meningitis first.
Yeah, risk depends on the underlying issue. Patients with lymphoma, CLL, intensive chemo, BMT recipients, especially those with antibody deficiencies, they're at high risk.
And for those antibody-deficient patients, it's the encapsulated bacteria again.
Overwhelming meningitis risk from S. pneumonia, H. influenza, and meningitis, because antibodies are key for them. But patients with cellular immune defects, T-cell problems, they're susceptible to a different range of CNS pathogens, listed back in Table 74-3. CNS TB is a consideration too, especially from endemic areas.
What about encephalitis? Brain inflammation itself.
Again, an expanded list of possible causes in immunocompromised patients, much like in AIDS. Therapies that suppress T cells or cytokines really increase the risk from intracellular bugs and viruses.
Like high-dose chemo, fludarabine, anti-T-cell antibodies, anti-TNF drugs.
All of those. Specific agents mentioned include VZV-associated encephalitis, may be related to VZV causing blood vessel inflammation, also chronic viral infections causing dementia.
And progressive multifocal leukoencephalopathy, PML.
A really serious one, caused by JC virus. The source says you must consider it in a cancer patient with new dementia or focal neurosigns after chemo, especially after rituximab, the anti-B-cell antibody. That link is in Table 74-6.
Important to remember non-infectious mimics, too.
Absolutely. Normal pressure hydrocephalus, vasculitis from brain radiation, they can look similar. MRI is valuable for sorting things out.
And brain masses.
Can present with headache, maybe fever, focal neurosigns. Infectious causes are diverse. Bacteria like nocardia, fungi like cryptococcus or aspergillus, parasites like toxoplasma.
And non-infectious causes, too.
EBV-associated lymphoma can present as brain masses in these patients. Because the list is long and treatments vary wildly, the source states biopsy is often required for definitive diagnosis. Again, Table 74-6 is relevant.
Okay, pulmonary infections, lungs. Very common, very challenging.
And the diagnostic challenges start immediately. Again, that altered immune response in neutropenic patients.
Severe pneumonia without the classic signs. No sputum, no crackles.
Exactly. Even chest x-rays can be misleading early on. The source stresses standard x-rays just to screen. High-resolution CT is often needed because the infection might not cause obvious consolidation without enough immune cells. Table 74-7 covers this.
Getting samples sounds difficult, too.
Bronchoscopy can be risky with low platelets or instability. But if you can get bronchial lavage fluid, it's incredibly useful. They look for everything. Bacteria, fungi, including pneumocystis, atypical bacteria like Legionella, viruses, nocardia.
And pneumocystis is always a consideration.
Especially in those high-risk patients like ALL or lymphoma, not getting TMP-SMX prophylaxis, absolutely.
The source mentions the pattern of infiltrates on imaging helps guide things. Table 74-7 again?
Yeah, it gives clues. Nodular infiltrates, round spots, or masses strongly suggest fungal pneumonia, especially aspergillus or mucor, might need biopsy. Importantly, bacterial pneumonias in severely neutropenic patients usually don't cause those classic big lobar consolidations.
Okay, so if you do see a lobar pattern, think maybe less severe immunosuppression or a different bug.
Potentially. Diffuse interstitial infiltrates, that widespread hazy look, suggest viral, parasitic, or pneumocystis.
And the empirical approach there.
The source suggests maybe starting TMP-SMX for pneumocystis, plus something for atypical bacteria like a quinolone or azithromycin for chlamydia, mycoplasma, legionella, while you keep investigating.
Non-invasive tests can help too. Sputum stains, antigen tests.
Yes, staining-induced sputum for pneumocystis, serum cryptococcal antigen, urine Legionella antigen can all be useful adjuncts.
And those blood biomarkers, galactomannan and beta-D-glucan.
Useful, yes. Serum galactomannan points towards aspergillus. Beta-D-glucan can suggest pneumocystis, if not on prophylaxis or other fungi. But the source cautions they have limitations, sensitivity, specificity aren't perfect.
Let's talk specific lung bugs. Aspergillus, big concern.
Major concern. Need to distinguish colonization just living there from invasive disease,
And invasive disease is the dangerous one.
especially in neutropenic patients. Usually A. fumigatus or A. flavivus. It colonizes the airway, then invades blood vessels, causing tissue damage, clots, emboli. Risk directly correlates with how long the neutropenia lasts. Positive surveillance cultures might predict invasive disease.
How does it present clinically?
Often pleuritic chest pain, fever, cough, sometimes coughing up blood hemoptysis, which the source calls an ominous sign. Imaging shows new focal infiltrates or nodules.
And those specific imaging signs. Halo sign, crescent sign.
Characteristic, though not always there, the halo sign on CT is a nodule surrounded by ground glass opacity early on. Later, as the immune system recovers a bit, you might see the crescent sign air forming inside a cavitating lesion. Can actually appear as things are getting better.
And aspergillus isn't just lungs.
No, it can invade the sinuses, nose, palate, appears as a discolored necrotic area, often needs surgical debridement. Catheter infections need removal plus antifungals.
You mentioned antifungal prophylaxis has led to other fungi emerging.
Yeah, that's a consequence. We see more non-fumigatus aspergillus, aggressive mucorales causing mucormycosis, and things like Cedosporium or Lamentaspora. These often need different specific antifungals. Complicates things.
What about viral pneumonia?
Serious threat. RSV, influenza, parainfluenza can cause severe or fatal pneumonitis. CMV reactivation is a huge problem, especially post-HSCT.
But diagnostics are getting better.
Rapid PCR and multiplex panels help identify viruses quickly, allowing targeted treatment for flu or RSV, for example.
Okay, but crucially, non-infectious causes can mimic lung infections. Table 74-7 again.
Absolutely critical to remember. Chemotherapy-induced lung disease. Bloisen is famous for it, but others too. And radiation pneumonitis.
They cause fever, infiltrates, look just like infection.
Exactly. But the treatment is totally different, often steroids for radiation or some drug injuries, not antimicrobials. This leads to a major diagnostic dilemma.
How often is the diagnosis missed initially?
The source says even after bronchoscopy, a definitive diagnosis is missed in maybe 30% of cases.
So what's the next step? Gold standard?
Often open lung biopsy, or maybe a visualized thoracoscopic biopsy, but these are big procedures, maybe not feasible for very sick patients.
So if biopsy isn't an option,
Tough choice. Empirical treatment based on the pattern. TMP, SMX, quinolone for diffuse, antifungal for nodular, versus risking delay while trying other diagnostics. Source highlights risks on both sides, toxicity, wrong treatment versus delayed right treatment.
really underscores the complexity. Okay, brief stop at cardiovascular infections.
Source notes a few things. Elderly Hodgkin's patients can get persistent salmonella, sometimes hitting vascular sites.
And catheters again?
Those central lines, especially near the right atrium, increase risk of bacterial endocarditis infection of the heart valve lining, maybe irritation plus bacteremia.
Then there's non-bacterial thrombotic endocarditis.
Morantic.
Yeah, this is different. Sterile, no active infection on the valve. Linked to malignancies, especially solid tumors, also post-HSCT, presents as an embolic event plus a new murmur. Blood cultures are negative. Pathogenesis isn't fully clear, but strong cancer link.
And sometimes endocarditis can lead to a cancer diagnosis.
Right, if the bacteria causing it clearly came from the GI or GU tract, it might prompt a search that finds an underlying tumor there. Endocrine syndromes, infections there.
Rare but significant, source says. Hard to diagnose during neutropenia. Examples given. Candida thyroiditis found on scans after recovery, or CMV adrenalitis, maybe causing insufficiency.
The takeaway.
Any sudden weird endocrine issue in an immunocompromised patient, think infection in that organ.
Musculoskeletal infections, bones, muscles.
Can happen sometimes from vascular compromise by tumor or treatment. Diagnosis and therapy have caveats.
Okay.
Diagnosis: lack of inflammation signs in neutropenic patients means you might need aggressive tissue biopsy. Can't rely on just looking or feeling.
Yeah.
Therapy: aggressive surgical debridement might be needed, but tough with low platelets, bleeding, and low WBCs, secondary infection.
The source mentions clostridial bacteremia.
Yeah, C. perfringens in blood can mean different things. But isolating C. septicum from blood is strongly linked to underlying malignancy, leukemias, lymphomas, colon cancer.
And spontaneous bloodstream infections from the gut.
Reiteration of that point. Bugs like strep bovis 1 or C. perfringens showing up in blood might point to an invasive lesion like a tumor or polyp in the lower GI. Context is key.
Lastly, renal and ureteral infections.
Common when urine flow is blocked, as we discussed, table 74-1. Candida likes the kidney can invade from blood or ascend from the bladder. Persistent fungus in urine or fungus balls suggests invasive disease or onitis.
Viruses, too.
Specific ones seen in immunosuppressed patients. BK virus, polymavirus, post-BMT, and adenovirus, both linked to hemorrhagic cystitis bleeding from the bladder.
Okay, let's quickly revisit the underlying abnormalities just to really cement those connections. Lymphoid system first.
Antibody deficiency B-cell problems leads to those overwhelming encapsulated bacterial infections. Cellular immune defects T-cell problems leads to the intracellular bugs, fungi, viruses, parasites.
And intensive chemo hits both.
Often causes severe neutropenia and profound lymphocyte dysfunction. Complex vulnerability. That's why patients on steroids, calcineurin inhibitors, fludarabine, cytokine inhibitors need pneumocystis prophylaxis, hits T cells or key signals.
And drugs targeting B cells, like rituximab.
Increased vulnerability to certain viruses. Source highlights the PML risk, JC virus, with rituximab because B cells normally help control it.
And the hematopoietic system, the blood cell factory.
Source just hammers home. Granulocytopenia, especially neutrophils 500, is the dramatic risk factor, known since the 60s.
And despite prophylaxis, infections still happen often.
Yeah, source says 35–78% of febrile neutropenic patients with hematologic cancers still get documented infections.
The types of bugs vary.
Bacteria, fungi, viruses, parasites prevalence varies by location, patient factors. Anaerobes less common. TB, malaria important in some regions.
And the source of infection is usually.
Critically, their own microbial flora, skin, mucous membranes, gut. Gram-positives, gram-negatives from these sites, tables 74-4, are the main threat.
Understanding that endogenous source is key for treatment, right? Which brings us to treatment strategies, maybe following that logic in figure 74-2.
Exactly. Antibacterial therapy is job one when infection suspected. Mandatory, prompt initiation, no waiting.
Why the urgency?
Because these patients can go downhill incredibly fast. Rapid fatal infections are possible.
So the initial empirical regimen guidelines, figure 74 to
Needs broad coverage. Gram-negative and gram-positive aerobic bacteria, table 74-4 bugs. Monotherapy with drugs lacking good gram-positive cover like Cipro or Astrionam or an aminoglycoside alone, not adequate.
And local resistance patterns matter hugely.
Absolutely. Choice has to reflect hospital epidemiology.
Right.
A single third-gen cephalosporin might work if local resistance is super low, but often need broader cover.
What if they get fever while on prophylaxis?
Then your empirical choice needs to target bugs resistant to that prophylaxis or known breakthrough pathogens. Might mean more resistant gram-negatives or gram-positives not covered initially.
What about oral antibiotics?
Can be safe for carefully selected low-risk outpatients. Short expected neutropenia, 10 days. No major complications like hypotension or severe pain.
And prophylactic fluoroquinolones themselves.
Cipro or Levo. Large studies support giving them to a febrile patients expecting prolonged neutropenia, 7 days. Decreases bacterial infections, morbidity, mortality.
Okay, for those needing IV empirical therapy for prolonged neutropenia, common regimens.
Big trials show roughly equal efficacy for several broad-spectrum options covering Pseudomonas. Ceftazidime, Piptazo, or carbapenems like imipenemeropenem.
Any caveats with carbapenems?
Imipenem-cilastatin linked to higher C diff rates. Many centers reserve carbapenems for known ESBL-producing gram-negatives, not necessarily first-line empirical if other options work locally.
And vancomycin, not automatic up front.
Right. Despite frequent coag-neg staff from lines, routinely adding vanc empirically to everyone isn't recommended. No proven outcome benefit adds toxicity.
So use it only when strongly suspected.
Exactly. Strong suspicion or evidence of MRSA or significant coag-neg staph infection. Positive blood culture. Definite catheter site infection. Thoughtful prescribing needed. And again, check local sensitivity data constantly.
Okay, how do you refine therapy once started? Fig 74-2 follow-up.
Primarily guided by culture results, especially blood cultures. Surface swabs can be misleading. If you isolate a specific bug, optimize for it.
But don't just keep adding drugs blindly if they don't improve.
No. The source cautions against that. Adding more and more antibiotics without clear clinical or microbiological reason is inappropriate, potentially harmful. That planned progressive therapy isn't generally effective.
What about double coverage, using 2 antibiotics?
Nuance here. There's a rationale for synergy against tough bugs like Pseudomonas, beta-lactam plus aminoglycoside, but recent studies question the benefit versus toxicity. Just adding a second drug like a quinolone to a broad beta-lactam without proof of synergy. not shown beneficial, adds risks.
And watch out for antibiotic toxicities themselves.
Yeah, source mentions cephalosporins causing marrow suppression, vancomycin causing neutropenia too.
And inducing resistance.
Using multiple cephalosporins or 2 beta-lactams can induce beta-lactamases in bugs like Enterobacter, so maybe avoid those combos in that specific scenario.
Duration of therapy. Figure 74-2 again.
Traditional approach. Continue until neutropenia resolves. Count 500 for 2 days.
But newer thinking.
Source says it might be reasonable to stop after 72 hours if the patient's febrile and stable. Requires careful watching, not for everyone, but reflects a move away from rigid rules.
What if fever persists after neutrophils recover?
Differential diagnosis broadens. Less risk of sudden bacterial death allows a search. Could be fungal, undrained abscess, drug fever, virus, maybe GVHD in transplant patients. Can start removing unnecessary drugs and look harder.
Okay, antifungal therapy, also crucial.
And tightly linked to neutropenia, the major predisposition for invasive fungal infections.
Common culprits.
Candida species, albicans, tropicalis, but also cruceae, parapsilosis, glabrata, aspergillus species, fumigatus, flavus, occasionally mucor, rhizopus, fusarium, others. And that resistant Candida auris is a growing global concern.
So empirical antifungal therapy rationale. Added after 47 days of fever despite antibiotics.
Exactly. Because fungi are hard to culture early, and disseminated disease is deadly if treatment is delayed. Long-standing practice.
And then newer agents have improved things.
Definitely. Lipid formulations of amphotericin B are less toxic than the old standard. Echinocandins, like caspofungin, work for azole-resistant Candida and aspergillus, shown equivalent to liposomal ampho B for empirical use.
What are the azoles?
Fluconazole is good for many Candida, but limited spectrum, no aspergillus. Broad-spectrum azoles like voriconazole, posaconazole are great options for aspergillus, even in the CNS.
But no single drug covers everything.
Critically important point the source makes. Each drug has a different spectrum. Aspergillus terreus resists ampho B. Voriconazole hits pseudosiguria, but not mucor. Posaconazole does hit mucor. You have to know the bug and the drug profile.
Posaconazole also used for prophylaxis.
Yes, useful oral prophylaxis for expected prolonged neutropenia. Combination therapy studies are ongoing.
And fungal catheter infections.
Source repeats. Extremely hard to treat. Require catheter removal plus antifungals.
Antiviral therapy. More important now.
Growing importance, yeah. Effective drugs available, especially for herpes group viruses.
Like HSV and VZV.
Serious, sometimes fatal infections from herpes simplex and varicella zoster shingles in chemo patients. CMV disease is also serious, particularly devastating post-HSCT. Roles of HHV6, METATEV7 negatives still being figured out. EDV lymphoma happens with chemo, but much more common post-transplant.
Cyclover and related drugs are mainstays.
Lots of experience with the cyclover for treatment and prophylaxis. Newer agents offer advantages.
Respiratory viruses, too.
RSV can cause serious disease. Influenza is a known threat. Vaccinate if possible, though response may be poor. Use antivirals for treatment prophylaxis.
And COVID-19.
Source specifically mentions its disproportionate impact on cancer patients, especially lung cancer, making them more vulnerable to severe SARS-CoV-2.
Okay, any other therapeutic modalities?
Cytokines.
GCSF, GM-CSF. They boost neutrophil production, shorten the vulnerable period. But the source says most authorities recommend using them only when neutropenia is causing significant problems, like in febrile neutropenia, not routinely just alongside antimicrobials.
Potential side effects.
Fever, bone pain, low oxygen, inflammation, serositis.
And risk doesn't vanish completely after neutrophil recovery.
Decreases dramatically, but remains elevated for some things depending on ongoing drugs. Patients on maintenance steroids still need pneumocystis prophylaxis. All patients often need it throughout maintenance chemo.
Right, which leads perfectly into prevention strategies. The environment matters. Yeah, aspergillus outbreaks linked to hospital construction, stirring up spores. Suggests need for good HEPA air filtration in units caring for these patients.
What about strict isolation? Laminar flow rooms, gowns, gloves.
Concept exists, but source notes most centers don't use them routinely. Expensive, limited evidence of dramatic mortality benefit, and they question the validity given most infections are from the patient's own flora anyway.
But basic infection control is key.
Hand washing. Emphasizes mandatory for all staff and visitors to prevent spreading resistant bugs. Absolutely essential.
Dietary recommendations. The neutropenic diet.
Yeah, the idea of avoiding high bacteria foods like raw veggies. Source says a cooked canned food diet is fine, but points out there's actually limited strong evidence that any specific dietary restriction significantly cuts infection rates.
But common sense still applies.
Avoid leftovers, deli meats, undercooked meat, unpasteurized dairy, mainly due to listeria risk.
Physical measures.
Mostly common sense advice related to specific vulnerabilities, like careful skincare for lymphedema patients.
Immunoglobulin replacement, IVAG.
Discussed for documented antibody deficiencies, myeloma, CLL, post-allo, BMT. Current recommendations reserve it for severe, prolonged low IgG, 400 mg/dL, plus a history of repeated infections.
Not routine for all low levels.
No. For most CLL patients with low IgG, prophylactic antibiotics are cheaper, easier, and effective for preventing the bacterial infections they're prone to. Routine IVG generally not recommended.
Sexual practices.
Condoms recommended for severely immunocompromised. Avoid oral exposure to feces. Neutropenic patients should avoid practices causing trauma to mucous membranes creates entry points.
Finally, vaccination. Table 74-42 referenced. Big challenge is reduced response.
Yeah, patients on chemo often don't respond as well, but purified protein and inactivated vaccines are generally safe, almost never contraindicated, and should be given if needed, like TB boosters, seasonal flu.
Timing matters.
If possible, avoid giving during peak chemo intensity. Mid-cycle might be better. For planned splenectomy, give pneumococcal, meningococcal vaccines before surgery if possible. Habe vaccine for all splenectomized patients.
And live vaccines.
Absolutely contraindicated during intensive chemo. Risk of causing disseminated infection from the vaccine itself. Table 74-2 summarizes which are live, like MMR, varicella oral polio, and the recommendations based on immune status transplant timing.
Wow, okay. We have covered a massive amount of ground there.
We really have, from why patients are vulnerable to specific bugs in specific places, the diagnostic puzzles, treatment logic, prevention. It's a lot.
Going through it like this, piece by piece, from the direct tumor effects to the nuances of T-cell versus B-cell defects, the specific syndromes, the rationale for empirical therapy versus prophylaxis, it really builds that comprehensive picture.
That's the goal, right? Getting that deep dive into the material from Chapter 74, understanding these vulnerabilities, the specific pathogens, the altered presentations, the treatment logic. It's absolutely essential for navigating this complex landscape.
Whether you're involved in care, supporting someone, or just, trying to get that mastery level understanding we talked about.
Exactly. Grappling with the why behind the risks, the how of the diagnosis, the logic of the strategies that provides the robust grasp needed. It's the kind of understanding professionals in the field use daily.
It really highlights how fighting cancer isn't just about killing tumor cells, is it?
Not at all. It's an intricate battle on multiple fronts, including constantly defending the patient against these microbial invaders.
Which brings us maybe to a final thought from all this.
Well, one thing that strikes me from the material is this dynamic interplay. As cancer therapies get more sophisticated, more targeted, more effective against the cancer.
They often reveal new, sometimes unexpected, vulnerabilities to infection.
Precisely. It prompts ongoing research, adaptation, and supportive care. The fight against cancer seems inextricably linked to this dynamic, evolving fight against microbial threats.
A continuous challenge, constantly reshaping patient care.
Yeah. It's a reminder that staying ahead requires constant learning and vigilance in both areas.
A powerful way to wrap it up. Thanks for walking us through that incredible depth of detail.
My pleasure. It's a critical topic.